Okay, guys, so we're here with Caitlin again. We're
Still here.
let's go. All right, let's get that. All right,
This is video 2.
and we're back.
Take 25.
No, video 2 in the 17-part series of pediatric education.
All right, take 2, pediatric seizures. All right, guys. So we're gonna talk about some seizures real quick with Caitlin. I'm just gonna run through our protocol, what we've got available to us, how we would generally go through a pediatric assessment for a seizure, and then Caitlin's gonna kind of fill us in on stuff. So we either have the postictal route or the status epilepticus route. For status seizures, keeping their airway intact, or at least assessing it, making sure it's patent, checking that patient's glucose. If they are still seizing, at least the seizures that I've seen, it's not necessarily all like a full body seizure. Look at their eyes too. Look at their eyes, look at their tongue, body movement, all of that can kind of give you a hint as if they're seizing or not. But midazolam is our first line drug, or Versed, and then our second line is going to be Ativan. If you show up on scene for that seizure and the seizure is done with, postictal wise, check that patient's glucose. Kiddos don't have the reserves that we do when they have a seizure, so they burn through all that sugar. They could have another one instead of it being caused by whether it was epilepsy or a febrile seizure. Now they're having that seizure again because their glucose is low. Caitlin, you have anything?
Yeah.
So, where preferably would you check a patient's glucose, a kiddo?
Well, if you guys are gonna start an IV, I would check it when I start my IV, just to minimize the pokes. But if it's, if you just need to get a point of care glucose, just their finger, or if it's a baby, you could do their foot.
Okay.
Just a quick little heel stick.
Okay.
And check it.
Do you have any tips for starting pediatric IVs?
Oh, yeah, sure. I guess, I was real nervous about the IOs when I became a nurse, and then teaching PALS and going through it, and then the more I have worked with them now, the better those things are. So like if you're hesitant at all and you don't feel like you can get a vein, don't blow all of our sites, just put in the IO and we'll change it later. Especially if it's an emergency, I know it's scary, but well, it's probably not scary for you guys because you do it all the time, but just it helps a lot if it's if people try and they blow all the sites. It's hard for us when they get to the floor, come to the ER to get an IV that's working, because normally they're going to need an IV and then it's all my sites are blown. So but with kids too, you always want to make sure they're not as deep as you think they are. So when you're taking your needle, you want to make sure you're not, like an adult you might go in like this. On a kiddo, you want to go more perpendicular and kind of stay with the skin, I guess. The other thing I always do is I poke and then I take a breath myself.
Okay.
Because then that kind of helps the kid. The kid's trying to breathe too, because as soon as they're poked, they're scared and they're going to clamp and you're never going to be able to advance your catheter. So if you can poke, take a breath, and then kind of just slowly advance it, it goes a little bit better than if you just poke in there. And you guys carry 24 gauges, I would assume.
Yes. Yeah.
So you don't want it too small, but like 24s are still a good size if that's all you feel like you can get, and it still works just fine. We use them a lot. So our scalps are good. They don't have any valves, so you can go any way and it doesn't mess with anything.
Yeah. So is there preferred sites? I think we all default to like ACs for adults, but kiddos move around, wiggle a lot more. Is there better sites to start?
We don't love the ACs because they are hard for the kiddos if they're trying to suck their thumb or hold their teddy or their bottle or whatever, use their arms. But wherever you can get the site is better than nothing if you need it. So we like hands. If they're under walking age, the feet are better. The feet can work as long as they don't walk. Anytime I see a good scalp vein, I really love that. So it's my thing. It stays out of the way from everybody. But yeah, ACs are kind of tough because they don't get to move their arms. And as long as you can stabilize it and make sure you're have cotton underneath all the pressure sites so it's not putting into the skin, then the better. I actually have a picture, if you want to see it, of a kiddo that got taped too hard with all the sites in there, because kids are moving around and they don't want to they don't want to move, so they tape it as hard as they can, and then all those sites bear into the little arm. And so like if you can put cotton underneath it while you're taping it, or if you can at least just get it stable, and then we can always fix it up too.
Can you send that to me?
Right there.
So, for seizures, is there a general age range that kids have either febrile seizures or epilepsy gets diagnosed?
So usually epilepsy is diagnosed before the age of 5, and I suspect most of the kiddos that you would go on would not be known epileptics.
Yeah, it'd be a first time.
Right, it'd be a first time that you'd see it, or right, like the majority probably go on our febrile seizures. You might go on some diabetic seizures, or some, you might have trauma seizures, but for the most part, if it's, if they're calling you, it's because it's been a first time and the parents don't know how to handle it.
Yeah.
So.
No one's.
Yeah. Mm-hmm.
Febrile seizures. Tell us about why those seizures actually happen.
Sure. So febrile seizures happen not because the temp gets up so high, but because it rises so rapidly, or it comes down so rapidly. So everyone talks to those people, or maybe you guys do it, which you should stop, whatever, where you hear that your kid has a fever and you should get them in a cold bath. So they have this high temp, and then you put them in a cold bath, and it brings their temperature down too fast, and they have a seizure. Or oh, my kid's so hot, I took him outside because it's snowing out, and then it brings it down too fast, and the body can't compensate for it. So most of those seizures happen before the age of 5, if it's going to be a febrile seizure. And if they've had them before the age of 1, I think, don't quote me on this, they're gonna more likely to have it again if they have a febrile seizure before the age of 1. There's not really a whole lot you can do for it. Like by the time you guys get over there, they've probably already finished their seizure. So you just want to make sure, sugars are good, like you talked about, all that stuff. They're supported, families supported, all the kind of stuff to get them evaluated. 9 times out of 10, these kids come to the ER, and then they go right home. They don't even get admitted anymore. Like 5 years ago, we'd admit all of them. Now I don't hardly ever see any febrile seizures anymore. The one I have seen recently probably has epilepsy, but it probably started as a febrile seizure, or didn't start. There's it was maybe just coincidence, because they had a febrile seizure, came in, had a febrile seizure in the ER, and then had another seizure on the floor. And it was all, the kid had a temp the whole time, but he also had a virus. So they don't know if it was the virus or that, but he's gonna get a workup down in Denver, and he'll follow up.
So when you're talking about febrile seizures, is it more common that they just have one seizure
Yeah.
for an extended period of time, like you won't see it again?
Yeah, so usually they just have the one seizure, and then they don't ever have it again, and it doesn't last that long. It's usually done within a minute. It's just a quick little thing. Traumatizing for everybody, but it's not usually as, like if it's a true epilepsy diagnosis, they're gonna have seizures that last a little bit longer typically, or that are gonna need a little more treatment, I guess. Yeah. They're gonna know they're coming. I guess that makes sense too, right? I don't know if kids know if febrile seizures are coming, because they're usually little when they have them.
Versus like some adults have auras, or a feeling.
Yeah.
Something that they're gonna have one.
So you guys would probably go on the febrile seizures, and then we have a couple kids in town, and it's just becoming more and more popular to want to hurt yourself and come to WBI for an extended amount of time, unfortunately. And so we have a lot of kids that have seizures that are, I don't know how to say this nicely. They're not actual seizures. Some of them are faking it, and then some of them actually have seizure activity that's related to trauma. So the difference, how you can kind of tell, right, all this is, you can pick their hand up in front of their face and you can drop it, and if they stop it from hitting themselves in the head, it's not a true seizure. You can sternal rub them, that's kind of mean, that's not true. You can try and flick their eyelashes. If it's a true seizure, they're not going to care about any of that stuff. So these teenagers that are kind of manipulative, a lot of times too, if it's, if they're having this kind of seizure episode, you make sure it's a seizure versus not a seizure. But then also some of these kids in town that are having somatic seizures, so seizures caused by trauma, there's nothing you can do for them, and if you touch them, it makes it worse. So you have to sometimes just be like, you're safe, you're okay, help's coming, make sure their airway's okay, but you don't really get involved. So it's hard to determine. But
one thing we see with a lot of those calls will be the family saying, hey, they've had 10 or 15 seizures in the past I don't know, 8 minutes or something, a little kind of, so in that respect, I guess, say it the right way is like a reasonable number, but something that you'd be like, okay, this is what you would expect, say in 10-minute amount of time, if they had, 2 seizures, that
Yeah.
would
I would,
be more common.
yeah, and I would think if they're having more than 2, you would, and it was a true seizure, you would go into like status epilepticus, you wouldn't think that I don't think, it's hard because by the time they come up to peds, when we take care of them, it's been diagnosed and they don't usually ever have one again, even if it's an epilepsy diagnosis. So they start them on Keppra right away, so they're more calmed down when we see them. We don't see them with this activity. Now we do have those kids that come in that no one touched anything for the seizure because it's not a true seizure, and then they say they're having seizures or they act like they're having seizures and carrying on and all the things. But right, they're completely aware afterwards. They don't. That's how a couple of kids in town that do the somatic seizures, they are completely coherent throughout it. They're seizing and you can't get them to stop, and it looks like a true seizure, but they can hear you, they can sometimes even talk to you, and then afterwards they know exactly everything that's going on. They're not out of it at all. So it's kind of hard because it's, a true seizure medical diagnosis is like they don't know what's going on, they're totally out of it, they're postdictal, all the things, and then so seizures are hard to wade through. But typically, if it's not lasting more than 5 minutes, you don't really need to treat it. You need to just kind of support them and watch them and get them to the ER and then go from there. But it's all case by case basis.
How often do you see seizures being caused by like hypoglycemia in kids, or say an initial diagnosis type 1?
Sure.
Most kids are gonna be type 1 diabetics. Like they'll be diagnosed when they're young.
Yeah, so I don't see very many seizures caused by sugars because they are usually getting a trip right to Denver if they've seized because of DKA. So that means their pH is low, their pH is lower than we feel comfortable managing, and their brain is swelling, and that's not something we want to handle at the hospital. So just know that, that's the main thing with kiddos, right, is like they always teach you that if you don't know what's going on or what the cause is or they're out of it or any of that stuff, you always check a sugar because that's a real simple fix. And we actually just had a kiddo that came in, and she's 10 months old, so she can't talk or anything, and she was just kind of acting out of it, acting goofy, but still not acting enough that it was concerning the parents, just like she's not feeling good, she keeps having diarrhea, we're not sure what's going on. And we just can't get her to stop. Like she threw up and all this stuff. And so then when they did labs on her at the hospital, she ended up being like 48 glucose. And so then they were like, well, let's give her some formula and give her some, see if we can bump it up a little bit, some Pedialyte, whatever. And she did a point of care glucose, which is a finger stick, and it was actually 23. And so then they confirmed it with lab, and she was not like out of it, seizing, lethargic. She was just kind of like, she'd like kind of take a minute to lift her head up. So she doesn't have diabetes. She just depleted her whole reserve from diarrhea and vomiting going on too long. Okay. So she just got hypoglycemic, and so.
So definitely something like altered mental status in kiddos.
Yeah.
Okay, also check the sugar.
Yeah,
well.
but right, like how would we know she's altered mental status because we don't know her? So like with mom, it's like, is she just tired because she's got the stomach bug? So mom's like, well, no, she's been like, she can't really lift her head, or this is not her normal behavior. And she was on our floor for at least a couple days, and by the last day I had her, she was just starting to perk up and wanted to play a little bit, and so that took that whole time to get her almost back to baseline. So, and her sugars never really got above 80 because she depleted her whole store, so she has to build it back up. So right, like anyway, it's a whole thing. But and point of that is she was so low and she didn't seize. And then I've had kids that have been 600, 700 blood sugars and they haven't seized. So I don't know what the number is. I think it's all dependent on the kiddo. Yeah. But just know that it's a sign of both hypo and hyperglycemia.
Sweet. Got any more questions, Pat?
I don't think so.
Any tips? Assessing a kiddo, like I guess my things is arms and legs, but looking at their eyes has been for sure, like their arms and legs may not be moving, but their eyes are going back.
Sure, yep, so their eyes are going back and forth, and sometimes kiddos, the younger the kiddo is, sometimes they might just have, like a tick, almost like a lip smack that you wouldn't notice, like you just think, is that baby rooting, or does that baby wanna have a bottle, or what's going on, or or they might just do one like kind of little like hand, and it's just very, very subtle. But if you're getting called to a scene, I don't think you'd be getting called to a scene because of a lip smack. I think it would be more apparent. Not saying it can't happen, but for the most part, you would be having people call you because they're having a full-blown seizure. And then a lot of our parents that have new babies, they say they have seizures, and actually they're just having little apneic episodes where they have to figure out how to breathe and all the things. And so if they haven't quite figured out how to breathe yet, sometimes they'll hold their breath and they'll go apneic, and then they kind of do this weird pass out thing, and then they kind of like jitter. It's not a seizure, but it's still scary. It's still scary to parents. So sometimes you'll get calls for that, I would assume, maybe because we get a lot of those in the hospital where they're like, they stopped breathing and then they had a seizure, and it's like, I don't know if that was an actual seizure or just them going apneic. So main thing is supportive care. Check the sugar, make sure their airway's okay, their sat's okay, providing blow-by if they need it.
Thanks, Caitlin.
Good.
You're welcome. I don't know much about seizures because really we don't take care of them unless they're